All right. Good morning, good afternoon, or good evening to you. Thank you for joining us from various parts of the globe. And we always love to hear the questions you have for us because you stimulate our thinking and help us to bring content to you that's relevant and meaningful to you through these global tracheostomy webinars. For those of you who do not know me, I'm Vincia Pandian from Johns Hopkins University, and I'm here with Dr. Michael Brenner from University of Michigan, the president of Global Tracheostomy Collaborative, and Dr. Amy Freeman Sanderson, a member of our GTC Education Committee. Today's webinar is sponsored by an unrestricted educational grant from Medtronic and Smith Medicals, who have been strong supporters of tracheostomy-related initiatives at Global Tracheostomy Collaborative. Our panelists are not funded by them, and they will share the disclosures as appropriate. However, there's one disclosure I want to make today. Since we are going to be sharing information about surgical techniques, please be aware that there might be some graphic pictures or videos that might be a little difficult to watch, especially if you are a patient or a caregiver. So please use your judgment as you participate in today's webinar. If you have any questions during the webinar, please type them into the questions section in the control panel, and we will allow time for a panelist to answer your questions towards the end of this session. As many of you know, there have been discussions regarding the pros and cons of different techniques to perform tracheostomy during COVID-19 pandemic, and variations to traditional techniques have been used. Now that it has been a little over a year since the pandemic began, it would be educational to hear of all the different techniques various specialties, otolaryngologists, interventional pulmonologists, and thoracic surgeons have attempted to protect the healthcare team members and our patients. And so our webinar today aims to cover what worked and what did not, and if it did not work, why, as it pertains to percutaneous versus surgical techniques, for adults versus pediatric population, and for those with anatomical variations and the consideration of use of bronchoscopy versus ultrasound, and what are the implications of these considerations for those who are providing postoperative care. With that introduction, I will hand over to Michael to introduce our panelists.
Yeah, thank you so much, Vincia, and thanks to all of us who have joined us for this session. So we have three phenomenal panelists today representing three different disciplines. I'll just run the list in alphabetical order, starting with Dr. Auchincloss, is a thoracic surgeon at Massachusetts General Hospital and Harvard Medical School. Dr. Feller-Kopman is the Chief of Pulmonary and Critical Care Medicine at Dartmouth Hitchcock Medical Center and Professor of Medicine at the Geisel School of Medicine. And Dr. Hopkins is an assistant professor and pediatric otolaryngology section head at Cleveland Clinic's Head and Neck Institute. So let me just start with the introduction for Dr. Auchincloss. A thoracic surgeon at Massachusetts General Hospital. He received his MD from Harvard Medical School and completed his general surgery and cardiothoracic surgery training at Massachusetts General Hospital and joined the Division of Thoracic Surgery. His clinical expertise is in robotic lung, mediastinal, and esophageal surgery. He's the Associate Program Director of General Surgery at MGH and has a research interest in outcomes following lung and airway resection. He recently published techniques on how to perform a percutaneous tracheostomy in COVID-19 patients in the New England Journal of Medicine. So with that, I'm pleased to introduce Dr. Auchincloss.
Well, thank you very much for the introduction, and thank you for the invitation to speak today. I will be speaking about percutaneous tracheostomy, which is a skill set that I developed mostly on cardiothoracic surgery patients, particularly those on ECMO and mechanical circulatory support, but really got to put to good use during the peak of ICU admissions for COVID in the last year. So why do a perc trach? I guess I would flip that question around and say, why wouldn't you do a perc trach? There's no evidence to suggest that open tracheostomy is any better. And percutaneous tracheostomies consume far less resources. There's minimal setup. We don't have to move the patient to the ICU, from the ICU rather. There's no need to involve an OR team or an anesthesia team. Overall, it's just much less intrusive to the patient's care. We think of tracheostomies as something that advances the care of an ICU patient, and it's not fair to set them back by a half a day in order to perform the procedure. And then there may be some real benefits as well. So for example, it's very good in redo tracheostomies or in patients with prior neck surgery where the surgical planes are distorted. It's great in obese patients, and there may be less bleeding associated with percutaneous tracheostomy and maybe fewer mediastinal infections. The really critical points that I stress with all of my residents and fellows. So first is safety, and safety means do not lose the airway during this procedure. Losing the airway usually happens in one of two ways. Either the patient's inadvertently extubated, usually due to coughing from inadequate paralysis, or the balloon on the endotracheal tube can be ruptured. And both those things really turn a controlled procedure and into an uncontrolled procedure. The second is comfort. I really try to take the cues from the best ICU nurses I know, and I act as if every ICU patient were fully sensate and aware of everything that were happening. So the paralyze and apologize strategy of ICU procedures is not acceptable. These patients need to be well sedated and their pain needs to be controlled. And then efficacy. If we're going to do percutaneous tracheostomies, they have to be as good or better than open tracheostomies. That means they have to be low, midline, and we have to leave the patient with a perfectly fitted tracheostomy appliance. For setup, in terms of personnel, you'll need a skilled bronchoscopist and then someone to place the tracheostomy. We'll call them a tracheostomist, a respiratory therapist, and then an ICU nurse. You'll need a bronchoscope and then a percutaneous kit. We use this Cook Blue Rhino kit. There are competitors on the market. And then you'll need a tracheostomy appliance. Now the PERT kits are designed to go with a percutaneous tracheostomy, which is beveled and very stiff. But in practice, you can use any tracheostomy in this fashion. And in fact, it's quite important to be able to switch tracheostomies to suit the patient. Medications, as discussed, sedation and pain control are important, and paralysis is paramount. I give every patient either 100 milligrams of cisatracurium, 100 milligrams of rocuronium, or 10 milligrams of cisatracurium, and then I really do a lot of deep airway stimulation to ensure that they are totally paralyzed before I manipulate that endotracheal tube. I position every patient with their neck gently extended on a firm mattress. Most ICU mattresses have a CPR setting that works well for this. And then it's helpful to clear away all that detritus that builds up in the ICU, pillows, blankets, line dressings, and then the advantage is you get to leave the ICU room cleaner than you found it, which makes everyone happy. Technical pearls. So the incision is going to be a vertical midline incision that avoids any of the crossing structures like anterior jugular veins. It's about 3 centimeters, and it really can't be too low. I've never seen anyone with too low a percutaneous tracheostomy. I usually make mine a centimeter above the sternal notch. And I do a lot of blunt dissection down onto the airway. Almost every Seldinger type wire-guided procedure, central line placement, percutaneous chest tube placement, or percutaneous tracheostomy will fail if the soft tissue is not well dissected. It's easy to get needles and wires into structures and then hard to pass dilators if the soft tissue is in the way. And then I really believe that the endotracheal tube needs to be pulled back into the subglottic airway so that the procedure can be done under direct visualization. This is something I think ensures that the tracheostomy ends up in a perfect position, midline, low. Not everyone does it this way, but I think it's important. And then that needle, when it does enter the airway, should be at a right angle. It's tempting always to skive down obliquely underneath the sternum, and you'll pass the needle and the wire that way, but it becomes very difficult to pass a tracheostomy afterwards. So next I'm going to show the video, and as Vincia said before, just a warning to anyone in the audience that it is a video that depicts a real surgical procedure on a real patient. So. Patient is positioned with their neck extended, and we're going to make that 3 centimeter vertical midline incision. It overlies the second and third tracheal ring. And then we're going to do copious blunt dissection down on the airway, really scrape that soft tissue away from the airway so that it doesn't obstruct our dilators. This is the most important step. The RCU, the respiratory therapist and the bronchoscopist pull that endotracheal tube back in concert until you can visualize those subglottic landmarks. The tracheostomist is palpating the airway as a guide to when we're going to be well above the site of the tracheostomy. Once we're well positioned, we can stick with the needle. You see coming in at a right angle to the airway. And in the bottom right corner, we're going to see in a second the bronchoscopic view. And this is why it's so important to be able to see. You see that first needle pass felt right to the tracheostomist, but it was coming in eccentrically. So she's able to adjust and stick perfectly in the vertical midline. That's how we end up with a good tracheostomy position. Next, a wire is threaded into the distal airway, and the needle's removed. And now we're going to pass a series of dilators, first this small one, which we call a tracheal cracker, and then a graduated dilator, or the blue rhino, which is going to dilate that stoma up so that it will permit a tracheostomy appliance to follow. Here I'm placing just a 7-0 Portex non-percutaneous tracheostomy, and since everything is well dissected, it just follows that track very easily. I tend to position it 180 degrees rotated towards the head and then rotated into the airway. We'll move the ventilation over to the tracheostomy. And then before the endotracheal tube is going to be removed, I'm going to check the position of the tracheostomy with the patient's neck extended and flexed, and really make sure that we have the perfect appliance for that patient before we leave the procedure, because now is the time to fix it, not later. And with that, I'm happy to take any questions.
Thank you, Hugh, for sharing your experience in performing percutaneous tracheostomy for patients diagnosed with COVID-19. And congratulations again on your educational video being accepted in the New England Journal of Medicine. I heard that you had over 100,000 views already, so that's amazing. I do have a follow-up question to your presentation on techniques. What are the technical considerations that a surgeon, or did you say a tracheostomist? We call them proceduralists, that they should take into consideration when performing a percutaneous tracheostomy in bariatric patient population?
Yeah, I think so. Percutaneous tracheostomies are great for bariatric patients where to make an open incision really requires a very generous incision. Here, it's still difficult to palpate landmarks, but you can usually get to the midline trachea. It's important to size the tracheostomy appliance appropriately. That usually involves a proximal extra long tracheostomy tube, and that's where it becomes important to feel comfortable switching tracheostomy tubes during the procedure. And then a final consideration I'd say is that bariatric patients de-recruit very quickly. And so even brief periods of apnea and lacking positive pressure can be really detrimental. So I try to build in pauses in that procedure. So I may pass the wire and then advance the endotracheal tube again, inflate the cuff, and ventilate the patient for 5 minutes before going on to the next step.
Mm-hmm. So do you always make your decision based on a patient's BMI, or do you also palpate the anatomy and then make the decision saying, well, the anatomy is fine because of their body habitus?
Yeah, I think a lot of bariatric patients don't carry their weight in their neck, and sometimes even with very heavy patients, the anatomy can be relatively normal. I think it's just important to be flexible and also to be realistic, so that if you put that tracheostomy in and you look from above and if it looks too short, it is too short. So that's the time to switch it.
Mm-hmm. Mm-hmm. Thank you, Hugh. Michael, do you have any questions for him?
Yeah, could you comment, Hugh, about patients who are on ECMO? Maybe for the audience, you could explain what ECMO, or extracorporeal membrane oxygenation, is, and what the practical implications are in terms of both indications and safety.
So ECMO, extracorporeal membrane oxygenation, is basically putting someone on cardiopulmonary bypass in an ICU setting when they have such significant lung injury, or sometimes when they have such significant cardiac injury that they can't support their own oxygenation or circulation. And for our purposes, it's important because in order to be on that circuit, you almost always have to be anticoagulated. And so you're more prone to bleeding. And so having done a number of these procedures on patients where I didn't feel like we could safely stop blood thinners, we've developed a lot of techniques for avoiding what usually ends up being really nuisance bleeding, but can occasionally be life-threatening bleeding from a tracheostomy. And I think the most important thing that I've learned is to put a purse string suture around that tracheostomy site and really tie it snugly around the tracheostomy to create some hemostatic effect around it. And so that alone, that very simple maneuver, which I learned from the ECMO team at Toronto, where they do a lot of ECMO, that very simple maneuver really cut down on our bleeding complications by 90, 95%.
Mm-hmm.
Terrific. Thanks for that really thoughtful discussion and presentation. I really think that is the finest video that's currently available on percutaneous tracheostomy. It certainly filled a vital niche in our knowledge base about how to approach it during the pandemic. So now we'll move on to our next speaker. I'm very pleased to introduce Dr. Feller-Kopman. He's the Chief of Pulmonary and Critical Care Medicine at Dartmouth-Hitchcock Medical Center and is a professor of medicine at Geisel School of Medicine. His areas of clinical expertise include all aspects of interventional pulmonology, including the multidisciplinary evaluation and management of patients with complex central airway obstruction. In addition, he specializes in the evaluation and management of pleural disease and lung nodules. Dr. Feller-Kopman has published more than 225 peer-reviewed manuscripts, in addition to over 30 book chapters, and is co-editor for 4 textbooks. He's a fellow of the American College of Chest Physicians and a member of the American Thoracic Society, the American Association for Bronchology and Interventional Pulmonology, and the Miller-Colson Academy of Clinical Excellence at Johns Hopkins. It's a pleasure to introduce you to Dr. David Feller-Kopman.
Thank you, Michael, and thank you, Vincia, for the opportunity to present here. It was a great presentation by Dr. Auchincloss, and what you noticed in the video, perhaps more than anything, was the lack of bleeding. Typically in these procedures, it is generally a fairly dry procedure, which is wonderful. And percutaneous tracheostomy is actually associated with less bleeding complications than open tracheostomy, also associated with less risk of infection. So I think it's not only as good, I think it's probably better than surgical tracheostomy. There is a difference in the techniques, though, and in the 6 pictures on the left, you see the relationship of the stoma to the endotracheal tube. And you could see that it's distal to the endotracheal tube. So just as he was talking about obese patients having derecruitment after creation of the stoma, in the medical ICU in patients with severe lung disease, this could be a factor as well. And we saw this especially in patients with COVID-induced acute respiratory failure. And that is different than surgical tracheostomy on the right side of the screen, where the endotracheal tube is distal to the stoma. So the stoma can be created, you don't get any loss of derecruitment, and then very quickly pull the endotracheal tube back, insert the tracheostomy tube with minimal risk of derecruitment. So although I'm a huge fan of perc trachs, there are occasional patients who are very what we call PEEP sensitive, positive end expiratory pressure in the ICU, who may actually need surgical tracheostomy. Again, the data behind perc trach versus surgical tracheostomy is no difference in mortality. Perc trach is associated with a shorter procedure duration, a shorter waiting time for the procedure because you don't need to worry about OR schedules. Often has better cosmetic results because we try to keep the incision quite small, and that helps the bleeding as well because the tube tamponades any small skin bleeders. And then it's typically less expensive than operative tracheostomy unless the open tracheostomy is performed at bedside in the ICU, which most ICU nurses don't necessarily like, turning their ICU into an operating room. And likewise, most surgeons aren't familiar with bringing all those reusable equipments to the bedside. So PercTrach is a very nice combination of benefits there. In terms of other benefits, it clearly avoids transporting a critically ill patient. Anytime we transport someone in the hospital, we always have to worry about bad things that could happen during transport. And loss of airway is just one of these. We discussed the bleeding risks and the infection risks of PercTrach being lower than surgical tracheostomy. And recent guidelines actually recommend with level 1B evidence, which is a fairly high quality of evidence, as percutaneous as the procedure of choice. Again, we need to always consider each patient on an individual basis. So there are patients for whom surgical tracheostomy is the way to go. And we talked about the high PEEP requirements. If there's an emergent airway, currently PercTrach isn't recommended by most societies. That being said, I have performed PercTrach in an emergent airway situation more than once. And if you have the PercTrach equipment at bedside and it gets you an airway, that's a life-saving procedure, whereas you might not be able to perform a surgical tracheostomy quick enough. We talked about patients who have high bleeding risks, and not only is there a lower bleeding risk in standard patients, but as you mentioned, patients who are actively anticoagulated, be it for ECMO or because they had a recent coronary stent, PercTrach has less bleeding. And then, of course, if there's a high risk of loss of airway, so anybody who's had a history of difficult airway, difficult intubation, not having to transport those patients, and also having the guidance to do the procedure bronchoscopically significantly helps. As with all procedures, there is a learning curve, so it's important that not just the tracheostomist or the proceduralist be experienced, but one of the things that we did at Hopkins, 3 weeks into my time at Dartmouth, I was previously working with Vincia at Hopkins, and one of the wonderful things that Vincia really helped create was the multidisciplinary tracheostomy service. And we had a set group of anesthesiologists, a set group of proceduralists, and having that teamwork where you don't really even have to talk, you just know the nonverbal cues, really decreases complications. Now, during COVID, there was an initial big fear of tracheostomy being an aerosolized generating procedure and what the risks to healthcare workers would be. We published a nice global review on this where Michael actually took a big lead in this in Lancet Respiratory Medicine. And the recommendations are evolving. There are some things that I think are crucial no matter where you are in the pandemic. One is communication. Communication between the proceduralist and whoever's managing the airway is key. As you talked about, paralysis was especially important in patients with COVID, but we also wanted to do apnea. Apnea refers to holding ventilation just to make sure that once you create a hole in the trachea, you're not aerosolizing blood and COVID to healthcare workers. We put a viral filter on the ventilator circuit. And then some authors have suggested performing percutaneous tracheostomy in a similar fashion to surgical tracheostomy, where you're putting the endotracheal tube cuff distal to the stoma. And then some authors also recommended avoiding cautery. So this is two papers published by my friend and colleague Luis Angel, who was really deep in the belly of the beast during the height of the COVID pandemic at NYU. And the pictures show his modified PercTrach trach technique. Most recently, the bottom reference there, they've published over 400 patients with this technique where they advance the cuff of the ET tube, as can be seen in figure 3, distal to the stoma, put the perc trach parallel to the endotracheal tube, and then remove the endotracheal tube. Now, although I love Luis, I think this is a very novel way to go. This is not how I do it, even in COVID patients. We know that PPE works. We performed many tracheostomies in COVID patients at Hopkins, and there was zero risk to healthcare workers with appropriate PPE. And my recommendation is really not to alter your standard practice, only in specific settings. But this is one of the techniques that has been used. And likewise, the use of ultrasound to guide instead of a bronchoscope, such that you don't have to open up the ventilator circuit. We typically use ultrasound to look for vessels such as the anterior jugular or aberrant carotids or high-riding innominates and decreasing vascular complications, but people have also looked at this to help place tracheostomy tubes. And again, this just shows the differences in anterior tracheal vessels with different degrees of compression, and a high-riding innominate on the figure on the right. So the current recommendations during COVID, we generally do not perform this procedure earlier than 10 to 14 days, which is our standard timing to do this. The procedure should be performed in a negative pressure ICU room if able. The technique, the operative technique really depends on the operator, and you should have the most experienced team in the room for COVID patients, minimizing the number of people in the room. We would use a disposable bronchoscope such that the entire bronchoscope cart doesn't need to be brought in, instead just a little monitor that could be wiped down, and clearly use PPE. I'd be happy to entertain any questions. I encourage everybody to visit. This is a much nicer view than Baltimore. No offense, Vincia. You're muted again.
I'll give you a question, David, while Vincia is getting your sound working. So could you just comment a little bit, actually, on two things. First of all, if you could perhaps explain what de-recruitment is and why that's relevant to these patients. And secondly, what some of the benefits of tracheostomy are in this particular population in relation to sedation, rehabilitation, or otherwise.
Sure. So normally when you take a breath, the little tiny air sacs in your lung called alveoli open up, and when we exhale, they go down a little bit, but they don't fully collapse. And in patients with advanced lung disease, without the ventilator support, you have a lot of not only alveoli collapsing, but airways collapsing. And that de-recruitment could lead to very quick low oxygen levels, and also when the airways open up like this, there's a lot of shear stress on the airways, and that could actually cause lung injury. So we want to do our best to avoid cyclic atelectasis, closing of the airways, and de-recruitment. And the second part of your question, remind me?
Oh yeah, it actually unrelated, but what are the benefits of tracheostomy in this population, or what are the effects on patient recovery?
Yeah, so overall, there's been some controversial data regarding mortality, but some studies have actually shown just in the general population a mortality benefit to early tracheostomy. But then there are lots of other benefits, such as decreased sedative needs, improved mobilization. There's great data out of Australia about increased communication and patient comfort, less ICU length of stay, less hospital-acquired pneumonia. In COVID patients, we don't have long-term outcomes data. There's a paper or a letter actually just published in Annals of the American Thoracic Society showing a trend towards decreased sedation use. And we actually just submitted a paper, and actually you guys have a paper, I think that was your letter, Michael, And we actually just submitted a paper showing both decreased sedation and increased mobilization with early tracheostomy in COVID-specific patients.
Thanks for that perspective. Vincia, is your sound working?
Yes, I hope you can hear me.
Yes.
Good. So, yeah, thank you, Michael, and thank you, David. I know that Hopkins is going to terribly miss you because you mentioned about the multidisciplinary team that we put together, but you took that multidisciplinary to an interdisciplinary level. What that meant was you actually gave opportunity for nurses and respiratory therapists and speech pathologists to collaborate with you in making any and every clinical decisions as one team. So it's definitely been a pleasure working with you and having you on this platform. So can you please explain when you would consider performing a tracheostomy if the patient requires proning due to COVID-19?
Yeah, so that's a great question. So first of all, what is proning? So proning is a technique that we use to flip patients onto their stomach. We call supine when we lie on our back and prone when we lie on our stomach. And there's good data in patients without COVID that proning in acute respiratory distress syndrome improves mortality, which is wonderful. And then we have COVID-specific data, even before patients are sick enough to end up on a ventilator, that having patients lie on their stomach can improve their oxygen levels. But certainly when they're sick enough to be on a ventilator, proning also is of benefit. Now, these patients are really, really sick. And as with any procedure, I want to be sure that what I'm going to do to them is going to help them and not just do a procedure on them. We always weigh risks and benefits. And I want to be sure that someone with acute respiratory failure is getting better and not getting worse before I do a tracheostomy on them. So we typically do not do tracheostomy early in the course of COVID when patients are getting prone. But if the trend overall is improvement and the benefits of tracheostomy outweigh the risks, we will consider doing the tracheostomy. And if someone's had a tracheostomy but then subsequently deteriorates, having a tracheostomy is not a contraindication to proning. As with all airways, you need to be careful not to lose the airway, be it with an endotracheal tube or a tracheostomy, and that requires a team effort amongst nursing, the ICU physician, often expert in airway management, be it a pulmonologist or an anesthesiologist.
Thank you, David. What would you recommend specifically to nurses and respiratory therapists in terms of what they should do to protect the airway?
In the setting of proning?
Mm-hmm.
Yeah, so again, it's really having someone focused on the airway. And that is regardless of tracheostomy tube or endotracheal tube. Someone has to be controlling the airway and having it secured to the teeth, not necessarily just the lips, but really to the face. Other people are going to be managing the flip, but you need someone who's managing the airway, be it an endotracheal tube or a tracheostomy tube. Mm-hmm. Likewise, you always need plans B, C, and D. So if you lose the airway, these patients who are prone could get sick very, very quickly. They de-recruit, they get hypoxemic. So what is your choice of airway? If it's a fresh tracheostomy, clearly you're not going to try to put that in right away. You're going to do endotracheal intubation. You want an experienced airway provider. You may need a bronchoscope in the room, LMAs of various sizes, maybe a video laryngoscope. So you always need to plan for the worst and hope for the best.
Mm-hmm. Thank you, David. I'm going to invite you also to jump in if you have any thoughts about post-operative care. So we have a patient with a tracheostomy who's now being proned. What else can we do to secure the airway or prevent it from accidental decamation?
Yeah, I think that's, oh, I'm sorry.
I was going to jump in and say that I'm not a big believer in suturing tracheostomies in. I don't believe that prevents inadvertent decannulation in any circumstance. Ideally, you disconnect the tracheostomy from the circuit so that you don't have any rigid structures between the patient and their airway that it's going to, like a fixation point that it's going to pull out on. But that's not always possible in somebody that's that sick for the reasons that David said about de-recruitment. So it really just comes down to having somebody whose job it is to make sure that airway stays in. At MGH, we had a prone team that specifically came around to prone patients, and it was a group of people that did this all day long, and they got very good at that. And one person on the prone team was in charge of just watching the airway.
Thank you, Hugh. And David, do you have anything else to add?
No, I echo what Hugh just said.
I know sometimes folks also talk about having an extension to the tracheostomy tube, add that piece in there to help out. And I've also heard of folks talking about creating like a donut-shaped protective material around the trach tube, so that way there's more comfort for the patients as well.
Yeah, one of the issues that you have to worry about in general with proning is skin breakdown. So be it on the cheek or the face, but you have to be able to assess the skin, and the flange is going to have different stresses on the skin around the neck than if somebody was supine.
Thank you.
Well, it was a really terrific discussion. I really liked the points that you raised, Dr. Auchincloss, about your experience with a proning team. It really is a specialized situation, and I don't know how many centers have taken that approach, but that clearly adds a lot of value. And Dr. Feller-Copman, it's really been a pleasure having you as a collaborator over some years, and really I've seen how you've pioneered the field of interventional pulmonology, kind of populating departments around the country. One of my dearest colleagues here is actually one of your prodigies, so thanks for all your contributions and a wonderful talk. So now we're going to change gears a little bit to someone from my own specialty, otolaryngology, Dr. Brandon Hopkins. And we're going to discuss pediatric tracheostomy. So Dr. Hopkins is an assistant professor and the pediatric otolaryngology section head at Cleveland Clinic's Head and Neck Institute. He is the Institute's quality improvement officer and the surgical director of the Pediatric Center for Airway, Voice, and Swallowing. His surgical interests include multi-level airway obstruction, complex sleep, and the surgical care of patients with cleft and congenital anomalies. He's worked for several years improving the care of all patients at the Cleveland Clinic living with a tracheostomy. I've also had the pleasure of working with him on a couple of presentations at our National Academy. I'm delighted to have him speak to you on the topic of pediatric tracheostomy.
Well, thank you guys for having me. It's my pleasure to talk about the pediatric tracheostomy. And like Michael said, it's a little bit of a gear change because most of what we do in the pediatric world is an open tracheostomy approach. It's limited real estate, and we really don't have quite as much of a leisure, especially in the young children, to perform a percutaneous approach. And one of the kind of early things that are different is right at the beginning of any type of pediatric approach, we're always going to look at the airway with a rigid endoscopy, either before or after we place this tube. And I think the difference is from the exact time we're placing a tracheostomy, we're already looking for synchronous airway lesions and ways and what we're going to have to do to kind of move towards decannulation. So right when we put that trach in, we're trying to figure out how do we get that trach back out. Positioning the incision is actually pretty similar to the adult world from an open approach and even from a percutaneous approach. Neck extended, shoulder roll. We want to place this incision halfway between the cricoid and the sternal notch. The cricoid in the pediatric population is the most prominent kind of structure in the neck, which is a little different than our adult colleagues. After we make a tracheal incision, we're going to be really aggressive with defatting the subcutaneous tissues. This helps later for any skin maturation that we perform. We then divide the fascia vertically, divide the strap muscles until we're looking at the trachea and the thyroid gland. Once we see this, I think in the adult world, a lot of times you can place that tracheostomy tube above the thyroid, below the thyroid, or from a perc standpoint, maybe it even goes through the thyroid. In the pediatric, because of the limited real estate, we usually use cautery and kind of feather through that thyroid gland until we're seeing the tracheal rings. And I think one of the important things that you really have to consider is what is in the area. What can you really mess up? Things you can really mess up are the innominate artery, the top of lungs. This is, such a small area. Our incision's less than a centimeter sometimes. So it's really important to know where you're at. Once we identify the trachea, then another difference as opposed to the adults is we typically place stay sutures. These are sutures that are going to stay on the lateral aspect of our incision. We have to have really good communication with our anesthesia team in order to decrease the cuff of the balloon or make sure that endotracheal tube's placed very distally so we don't pop the cuff, especially in children with high ventilatory requirements, high PEEPs, and high FO2. What these stay sutures allow is they allow to pull that tracheostomy open and be able to kind of easily insert that tracheostomy tube. Post-operatively, they're also very helpful in terms of that kind of oh crap moment. If you dislodge the tracheostomy tube, you have a false passage, it allows you to pull that tracheostomy up and be able to put it in the right place. You have to make sure though, if you cross those strings, you really can get in trouble because you can pull the tracheostomy closed. So they really have to stay on the left, right side of the chest. Now that we have the stay sutures in place, we have to decide how are we going to enter the airway. In the classic, for a pediatric population, most of the time we're going to make a vertical incision on the far right screen. Adult population, from an open approach, sometimes we'll use a Bjork flap like in the middle or an H-type incision. It's interesting though, we really pay a lot of attention and looked really closely at the type of incision and the consequences to healing after you make that incision. And they looked at this in the early 80s in terms of flow dynamics, and we'll show you what that means. Here you can see on the left, a classic Bjork flap is performed. In the middle is a vertical incision, and on the far right is a horizontal incision. And what they did was they placed the tracheostomy, they left it in place, and then removed the tubes and allowed healing to take place. And what was shown was that vertical incision was actually the type of airway that caused the least airway resistance. Even though it has that A-frame deformity, the airflow is still better in that than in either of their two techniques. And since that time, the vertical incision is what we've typically used. It's interesting though, in a pediatric population, small changes in diameter of the airway drastically impact the flow of air and the resistance of air. And I think we don't get away with very much. And I think in the adult population, because the airway is already so big, whether you place a percutaneous trach or however you make a hole in the airway, even when it heals, there's less resistance of airflow because that diameter is inversely proportional to the flow. For instance, on this picture, you can see they have suprastomal collapse above the tracheostomy tube, where that tube is collapsed down into the airway. Before we were able to decannulate this patient, we had to place a costal cartilage graft and perform an airway reconstruction, because even though this collapse wasn't drastically large, the amount of airflow didn't allow this patient to decannulate. Now, after we've made the incision in the trachea, however we've chosen to do that, we have to ask ourselves, how much of the skin are we going to tack down to the tracheal wall? Now, this is a very formal approach called a Bjork flap that is a common approach in the adult population and not really used in the peds so much, but this is a great example of a really mature stoma where that trachea is directly connected to the skin. That way, in case of a decannulation, it's much easier and more likely to get the tube back in the airway. For our pediatric patients, we have kind of some techniques that are very formalized from a stoma standpoint as well. This is a technique kind of popularized in the early 2000s by Coltai, where you make a cross incision on the skin and then a T incision in the trachea and really formalize the stoma, very much like a laryngectomy stoma for an adult population. This is nice because if you decannulate or the tube accidentally comes out, this hole stays open. It's very wide, and you're going to be able to put that tube back in, and it remains very safe. It's interesting though, because what we know is when you mature a stoma that much, you're going to decrease your rate of false passage, putting the tube down, parallel to the trachea, you're going to be able to kind of reinsert that tube easier. But there are downsides of that as well. Because I think what you trade is you trade that early tube security. You trade that ability to get a tracheostomy tube back in place with a very mature stoma. What I mean by that is a lot of times the hole is bigger, it's more mature, and then when we move towards decannulation, because like I said, in a pediatric world, most of the time, we're trying to figure out how to take that trach out as soon as we put it in. And if you have a very mature stoma, you'll a lot of times either have to put a cartilage graft on top, or you run a risk of scarring later that's going to impact airflow and cause stridor and really not maintain decannulation. After the tracheostomy tube's placed, we then secure the tracheostomy tube with neckties, either with a shoestring tie on the left or with a soft collar. I've typically moved to a soft collar with a straight flange on the tracheostomy tube. I find it digs into the neck much less, especially on cardiac children or kids with very small necks. And then in direct opposition to our adult colleagues, most of the pediatric world are very large advocates of flange sutures. But I do think it's a different situation. On a pediatric tracheostomy tube, a lot of times we'll have 3 centimeters to 4 centimeters of actual tube. So tiny movements of that base plate from the neck put us at risk of decannulation. So, you know, I place them on everybody, but I do think that when we place them, we need to place them as close to that tube and as close to the base plate as possible, because the further out you place them, the more anterior to posterior wiggle you have. In an adult, I'm not convinced that these flange sutures impact decannulation rates or false passage rates, because the tube is so long. You'd have to get them really far away from the neck, for these are probably not going to serve much of a purpose, and may even get in the way in case of emergency of replacing that tracheostomy tube. That's the downside of them. But there also is another downside, and it's on the next kind of image for us. You can see here, this is what I'm a huge advocate of avoiding. If you are going to use these flange sutures in adults or peds, please don't put them so far laterally. What this does is it really makes trach care difficult. It makes putting the trach tie and the collar on, you know, it's painful for the patients, and it can even lead to a lot of skin breakdown issues as well. And these are some great examples of that skin breakdown, because you know the sutures are really far out. I think when you're with a ventilator, it really loads the tracheostomy tube, and it really puts a lot of pressure on the skin, and it can cause lots of breakdown, and nobody loves this. It hurts the patients, and I think this has really pushed a lot of people away from flange sutures, but I think you can avoid that if you put them a little closer. So with that, I'm happy to open up the questions and happy to answer any you have.
Thank you, Brandon. Being an adult acute care nurse practitioner and having had minimal exposure to pediatric population, it was enlightening to learn of all the variations with incisions and flaps that can be done. I know some of these are actually applicable to adults as well, but many of them were actually new to me. So thank you, Brandon. I'm very grateful that you shared all of these. I was also especially excited that you talked about stay sutures. Because it seems like it's more the norm in the pediatric world, but in the adult world, it actually perplexes many of our nurses and respiratory therapists. So can you take a moment to explain to our colleagues here what they should do, they meaning nurses and respiratory therapists, what should they do if they see stay sutures in place, meaning how should they care for it once you send the patient back to the ICU room?
Yeah, I mean, we've recently updated our policy at the Cleveland Clinic, because I think that we were, you know, a lot of our respiratory therapists and nurses were left in a lurch a little bit, because, you know, once the surgeon placed the trach, they were disappeared to the wind and nobody knew what to do with these. One, I think that if your surgeon's going to use stay sutures in the adult population, and I think there's arguments both ways, I think you should really advocate for putting them as close to the base plate as possible, as medial as you can get them. That way you can perform good skin care. You can even fit a hydrophilic foam if needed, if there's skin breakdown, under the flanges if you place them really close medially. If you place them laterally, you see people stuffing foam or stuffing gauze between the flange sutures and the base plate, which I think is a bad idea. Typically our kind of guidelines is in a non-difficult airway, then we will, anytime after 5 days, those sutures can be removed by nursing or respiratory, or we can even fast track people to our long-term care facilities or short-term care facilities, and they can remove those stay sutures there if they're a non-difficult airway. If they're a difficult airway, our recommendation is to leave them in place till day 7. And on our difficult airway patients, the proceduralist or the tracheostomy is the person who makes that first trach change, as opposed to our respiratory team. Non-difficult airways, our respiratory team does the first trach change.
Mm-hmm. So you mentioned that nurses and respiratory therapists could also remove it. In your the picture that you showed, there was a left string and a right string on both sides. In the adult world, I feel like they end up tying both as like one piece that's hanging out. What would be the best way for a nurse or a respiratory therapist to remove it safely without causing any additional harm?
So let me clarify, are you talking the flange sutures or are you talking the stay sutures?
The stay sutures.
Yeah, the stay sutures, you know, I would probably advocate more for the proceduralists to take them out, because mainly the reason we put those in the pediatric world is because we're worried about that first trach change. We want to be able to pull those stay sutures up to the skin, open the kind of lumen of the trachea to be able to reinsert that tube. And typically after the first trach change, then those can be cut and removed. But I would really advocate, if people are using true stay sutures, they need to have a left and a right label on them with a tegaderm on the chest. And I even, think that there should be some suture left out. So because usually if you're going to use those, it's a kind of oh crap moment, and you really want to have a good plan. But again, if you cross the, never cross the beams, right? Ghostbusters. You don't want to cross the beams, because if the trachea is closed, you get into a bad situation.
Mm-hmm. Thank you for clarifying the flange sutures versus the stay sutures. Do you ever send a patient home with a stay suture in place?
I can't say that I would. I mean, I think if I have stay sutures in place, I'm still pretty worried about the airway. If I'm not worried about the airway, they still need to be in-house.
Thank you. Michael?
I just wanted to acknowledge, Brandon, the phenomenal work that you've done at Cleveland Clinic. It's a major heavy lift to implement a tracheostomy team. And when we learned about the work that you had done there, we were really thoroughly impressed. And also, for those in the audience, also note that although Brandon is a pediatric otolaryngologist, he actually has overseen the entire quality improvement efforts for the entire institute for our department. And that's been really, really a very valuable contribution since he arrived there. I think that I'll probably hand it off to Dr. Freeman Sanderson so that she can take some of the questions from the audience.
Thanks very much. And thank you again to all the panelists for a great presentation and discussion. There are a couple of questions from the audience, and I'm going to categorize them into sort of considerations pre-insertion, care during, and then some follow-up weaning questions. So they're sort of the categories. Excuse me. So it's in regards to insertions and use of ultrasound. So we saw, Dr. Feller-Kopman, you discussed the use of ultrasound. So really from the audience, a question about, do you typically always use ultrasound in regards to looking at neck anatomy?
Yeah, so very good question. So ultrasound is one of those things that has really changed practice throughout the chest and up to here for me. And one of the wonderful things is that it's really readily available in almost every ICU. There's almost no downside of using ultrasound. And the benefits are that it just gives you a sense of what's under the skin before you make an incision. So I'm a big believer in ultrasound. Now, that being said, the risk of bleeding complications with percutaneous tracheostomy are so low that in order to design a study to show a clinically significant reduction in those complications would probably need 1,200 patients per arm at least. What it could help, and where it's helped us, is as the only non-surgeon on the panel, if I see a big vessel right anterior to the trachea, I'm just going to let my surgeon do that one. There's no reason I need to get into that.
Yeah, thank you. And I guess following on from bleeding, there is a question around, particularly around ECMO patients. So Dr. Auchincloss, looking at patients' coag. So is that a relative co-indication to doing a PERC tracheostomy?
I don't think so. I've gotten very liberal with my feelings about what acceptable coagulation is. My sense is I ask the nurse if the patient seems clinically coagulopathic. So if they have bleeding around their nares from a nasogastric tube, that worries me more than any sort of objective number. And there are a lot of patients where simply we can't stop the anticoagulation, particularly fresh cardiac stents, and they're on antiplatelet agents. And certainly the risk there, I think, favors going ahead with the tracheostomy without stopping it. And I haven't found a lot of bleeding complications in those patients.
Okay, so I mean, in terms of at a decision, would you come to a decision about open versus PERC, and what sways your decision? So the question is, when do you consider a PERC not appropriate and opt for an open tracheostomy?
I wouldn't use coagulopathy as a guide. As David alluded, if I see a large vessel that I think is going to be a sort of an anatomic challenge, then I would do an open approach.
Okay, yeah, okay. Thank you for that. And then one more question for insertion around, we talked about bariatric patients. What about people very cachectic with very small necks? Are there any other different considerations for insertion size or incision size?
Typically, patients that are cachectic are technically quite easy to put tracheostomies in. The landmarks are so superficial. But occasionally you will see that the curve of the tracheostomy, that it's too deep. And I find that can usually be remedied just by putting a sponge underneath the flange to sort of get it to stick out a little bit more. But I don't think you need to undersize the tracheostomy for that.
Okay, thank you. Moving on now to the care of the tracheostomy, and this could be for both open or PERC. The question is from one of the SLPs. So they find that the percutaneous, when the patient needs a tracheostomy change, that PERC trachees can result in increased bleeding. So that first change, any comments about that in terms of complications or differences in complications at that first change for PERC versus open from any of the panelists?
I don't think I've had that experience of increased bleeding with the first change. I usually wait until, and I'd be interested to hear what the rest of the panelists do, but I usually wait until day 10 to do a unguided tracheostomy change. If I'm doing it before that for some reason, then I will typically set up as if I'm doing a percutaneous tracheostomy. I'll have the patient paralyzed. I will intubate them from above to have a secure airway, and then I'll do the tracheostomy exchange under direct vision. But I've not found bleeding to be a particular concern in those patients.
Okay, thank you. Yeah, and that's a great thought. So what about the other panelists? When do you typically recommend the first tracheostomy change with your patients?
So I agree with Hugh that there's generally no reason to do it clinically before day 10. And honestly, depending on where you're practicing and ability to get patients out of the hospital, there's really not necessarily a reason to do it before day 30. We don't know when the first trach change should be done. It probably shouldn't go on much longer than that. There's always risk of loss of airway the earlier you do it. In Boston, for example, where I trained, there were great long-term acute care facilities. So about 90% of the patients that I did a tracheostomy on were out of the ICU within 48 hours. That's not the case in Maryland. So in Maryland, people would stay in the ICU for weeks and weeks and weeks. So unless there was a clinical indication to do a tracheostomy change in Maryland, for example, communication, downsizing towards decannulation, we actually lengthened it from my typical practice of after 10 days to about 30 days.
Yeah.
Yeah, so I think that it's very similar here. We worked really aggressively to unify all the care pathway for trach changes and such. Pediatrics, I think, is a little unique where I think it's important to be present during that first trach change, because I think that a false passage and decannulation is such high risk and traumatic and detrimental if you have that. So we usually change that at day 7, sometimes at day 5. Our adult population here, we have moved to anybody who's not a difficult airway, following the manufacturer's suggested guidelines, which is 30 days. So we want them out of the hospital as quick as we can, from length of stay and from a safety and a rehab standpoint. So even with the sutures in place, we'll move them there and then change them at day 30. But again, I think you have to be thoughtful of that difficult airway population. And I really want to make sure our surgeons are present, or somebody that can obtain an airway is present to that first trach change, which we do on day 7. We have found, like with our perc trachs, most of our cardiothoracic and interventional pulmonary team, or pulmonary team who places them, the Bivona is typically the tube that they use and place. And I think that when they do change them early, because that tract is so well formed and nice, that I think we get some of those same concerns with just popping through the trachea and having some more oozing from that area. But when they move to 30 days, the trach change, there's no blood. It's as good as it's perfect. So
yeah, okay.
Less is more, I think, is the approach we've taken.
Yeah, and just moving on to my final category in regards to weaning, and Dr. Hopkins, you mentioned as soon as you're putting the tracheostomy in, you're thinking, what are the steps to getting this out? So 2 questions to round up the Q&A. I wanted to ask about then progressing weaning and cuff deflation use of speaking valve, particularly if the stoma is bigger. I'm just wondering, what, in your experience, sort of that, or everyone's experience, open versus perc, which has been different for use of speaking valve, and which has led to more successful use earlier on?
Would you like me to start, Amy? Or
yes, that'd be great.
So I have kind of a minimal maturation. My typical technique is I use 2 sutures from the skin to the trachea with a vertical incision. I don't do a starplasty or Bjork flap, mainly because of that exact point. If you create a big hole in the anterior tracheal wall, as soon as I move to a cuffless trach or a deflated cuff and I put a passing mirror valve on, so much of that air comes out around the outside of that tube that I can't get them to phonate. And if I can't get them to phonate, they also don't swallow, and it really slows down my decannulation process for a child. So I want a tight stoma. I want to be able to deflate my tube, put a passing mirror valve, have them move air back and forth, and then I think the decannulation in children is a little harder, but usually a 2-day capping, 2-day decannulation trial, but a little different than the adult population. A little more formal decannulation process, I think.
Yep. And what about from the other panelists? Do you have any comments to add around this?
This is one of the reasons I stopped putting in the percutaneous tracheostomies, because they're so thick. They have a very large outer diameter, and I found that when I was putting in even a 6 perc Shiley and definitely an 8 perc Shiley, that those patients were at least 1 downsize away from being able to wear a speaking valve. Whereas if I start with a normal flexible 7 Portex tracheostomy, most of those patients can speak as soon as they're off the ventilator.
Agreed.
Yeah.
Agreed.
Okay. So it's really, I mean, we were talking a lot about looking at the patients and clients afterwards. So those considerations, so straight after you're putting in the tracheostomy, how soon are they going to be able to be talking and engaging in that early rehab? So it's a consideration in sizing and type. And the last question that I wanted to ask, it relates to airway stenosis, and everyone touched on this in regards to the type of incision and the type of technique they use. In regards to the MDT team, when we're seeing clients perhaps post-decannulation or just before they're about to be decannulated, what considerations should the team look out for in terms of stenosis, and what are the red flags for this? So maybe Dr. Hopkins, do you want to take that first?
Yeah, I mean, that's I just left our airway clinic before I came here, and that's my whole world most of the time. It's really, can they cap? Can they use a speaking valve? Are there issues with having to go up on cuff inflation pressures using the ventilator? Is the tube too big? Sometimes you have to put a smaller tube in, and increase the risk of a mucus plug in a child in order to get them to move enough air around the tracheostomy tube. So, you know, when we're really moving towards decannulation or moving towards optimizing speech and language, we will do more formal airway evaluations on these children in the OR to kind of get a better idea of that suprastomal area. And in a kid, sometimes it's hard to get a transglottic view while they're awake, although it is possible and doable, but it's harder. So.
Yeah. And any other comments from the other panelists about about stenosis in the adult population and how the MDT team can support identifying patients at risk of this?
Yeah, if a patient, go ahead, David.
I think it's likely underdiagnosed. You know, adults have a decent amount of real estate as opposed to the pediatric population, and you often don't get symptoms of shortness of breath with exertion until you have lost a significant amount of airway. You know, normal male trachea is maybe around 18 to 20 millimeters and a female slightly smaller, but you don't get exertional shortness of breath until your airway is about 8 millimeters. So there are a lot of people, due to all the problems that cause them to get a tracheostomy in the first place, who may not show up for follow-up or may have deconditioning, and they don't realize that their shortness of breath is due to airway obstruction.
Yeah, thank you. Dr. Auchincloss, did you have any comment to add onto that? No. I just wanted to thank the audience as well for writing in your questions. I'm aware there's more questions, but I'm also aware of the time, so we'll collect those and we'll respond to you in due course. So thank you.
Thank you, Amy, for moderating the questions from our audience, and a big thank you to all our panelists. So here are the contact information with emails and Twitter handles. You're welcome to take a screenshot, or or you can watch it later. We will be sending a link to today's webinar in the next 24 to 48 hours. So please feel free to share it with your colleagues who were unable to attend today, but may benefit from this discussion presentation that we had. And we have a call out for all levels of writers. If any of you are interested in increasing awareness about any aspect of tracheostomy care, or if you have a kudos or good news to share about tracheostomy related outcomes, I want to invite you to contribute to our quarterly newsletter that is disseminated globally. Before we conclude, I want to invite you to join Global Tracheostomy Collaborative if you're not a member already. We have 3 levels of membership: healthcare professionals, hospitals, and patient and family memberships. Whether you are already a member or not, if you have any questions, please contact us at www.globaltrach.org. Thank you, and see you in a couple of months when we actually will be presenting on airway stenosis. So we'll continue our discussion very soon. In the meantime, stay healthy, wash your hands, and don't forget to get vaccinated.